Good afternoon. I am Dr. Sylvia Opanga. I am a clinical pharmacist and I'm a lecturer at the University of Nairobi. I teach undergraduate, master's and PhD in clinical pharmacy. And today we are going to discuss pharmaceutical care. So what is pharmaceutical care and how does it impact on universal health care? I will quote Hepler and Strand, who are the mothers and Hepler, Sipel and Strand, and that's who I like to refer to as the mothers and fathers of clinical pharmacy. And they describe pharmaceutical care as the responsible provision of therapy, which is meant to achieve definite outcomes that will improve the patient's quality of life. Now, how does this apply to us as pharmacists? The application is simple. What they mean by responsible provision of health care, or rather drug therapy, is you're providing the patients with drugs and you're responsible for that. By being responsible for that, I mean that you're giving the patient medication. You will evaluate the patient's response to that medication. You will follow up the patient and you will be responsible for any outcomes that happen to that patient. So you provide that drug therapy and your main goal is the patient is going to improve. And that improvement is supposed to improve the quality of life of the patients. What we have done traditionally as pharmacists in Kenya is that you do your mili mara tatu, you give that to the patient, and you will never see your patient again. You have no idea what they are. You have no idea who they are. You have no idea what else they're suffering from. You just service a prescription and you let them go. But now the paradigm has to change. We have to be those pharmacists that fully evaluate patients, either in an inpatient or an outpatient setting. You fully evaluate your patient. And by fully evaluating your patient, you're looking to diagnose medication-related problems and solve them. Medics usually do diagnosis of disease and prescribe. But for us, it's a different way of diagnosing. And what we are looking out for is medication-related problems. And then how are we going to then draw a pharmaceutical care plan to solve this medication? I'll give an example. When a patient walks in, what is a pharmacist supposed to do? And I always tell this to my students. I always ask them this question. When a patient walks into your facility, what do you do with them? Sometimes I get blank stares, and then I have to go and explain that a pharmaceutical consult, or what we call a pharmacotherapy worker, it involves getting the patient to sit down. Have a consultation room first of all. The traditional pharmacy window thing is gone. It is dead. Those days are done. Have a consultation room like I have one here. And then once you have that consultation room, take a patient's detailed history. And that history will include the history of their current illnesses, history of medications that they have taken before, social history, which means are there any practices or anything in their social life, for example their lifestyle, that can affect medication adherence or they can predispose them to disease. Ask about their family. Do they have family history of, for example, drug reactions? Do they have family history of chronic illnesses? And then after you've taken that history, including the history of what is bringing them to your facility. And remember, the pharmacy is always the first point of contact for the patients. Before they find their way in hospital, these people will pass by your pharmacy. So you have to do a detailed workup of the patient, do a detailed history. Once you do a detailed history, review the patient, what we call review of systems. You have to ask the patient what they're feeling from head to toe. Sometimes when you're diagnosing, people just focus on what has brought the patient to the facility. But as a pharmacist, you need to ask, apart from what you're feeling, is there anything else? So that you have a complete picture of your patient. Physical examination will be important. You might want to find out what are the patient's blood pressures, for example. What are the patient's vitals? And in clinical pharmacy, we will go deeper into other physical examination techniques such as inspection, auscultation, palpation, and percussion. The reason we are doing this, we are using these techniques is not to diagnose disease, no. The reason is, if I'm giving a patient medication, let's say somebody has fluid in the lungs, yes? And then I give them furosemide. I might need to listen to the lungs to see if my furosemide is working or if the patient's lungs are clear. I'm doing that for the purpose of clear outcomes for my medication and not for diagnosis of pulmonary disease. So physical examination is important for our patients. Now, once you have this detailed history of a patient, and then you have objective information from your physical exam, then you can correlate this information, or rather you can collate this information and then come up with a comprehensive pharmaceutical care plan. So from what you have evaluated the patient on, you have what is called a problem list. So you list all the medication related problems that the patient may be having. And then after that, what is your plan for this patient? If a patient has been on an underdose of medication, how are you going to adjust therapy? If a patient is non-adherent to medication, how are you going to solve that issue? If a patient cannot afford their medication, how are you going to help them? And that also includes issues of economics, okay? Because a lot of people may be saying, let's give this patient an original drug. They cannot afford. That means you can have that prescription, the patient cannot afford, you end up with a medication-related problem, the quality of life of the patient gets worse because they simply cannot access medication. So basically what I'm trying to say in all this is that as a pharmacist, you need to do a comprehensive workup of a patient and then come up with solutions to their medication-related issues. And I always tell pharmacists, there's so much that you know that you don't practice. There's so much that you do not do for patients. And if patients actually knew that you are supposed to do these things, they will hold you accountable for that. So the paradigm now as we look at universal healthcare is, we have to move from just dispensing medication or just being providers of medication or distributors of medication, but we have to be these people who are offering patient consults. The patient should be able to say, I'm from my gynecologist, I've received my gynecology consult, and then I will go for my pharmacist consult, and then the pharmacist is the last person who is always with the patient as they leave. So we have to, I don't see how medics can do this, and we don't do this yet. We are trained at the same level. And that brings in the issues of the constant fighting with lower cadre pharmacy practitioners. That this should be the end of it, because trust me, diploma guys have been doing what they have been trained to do best, which is dispensing. But pharmacists have not been doing what they are supposed to do, which is patient consultation. And once patients are consulted, they actually they know your value. And then pharmaceutical care is also something that cannot be practiced in a silo. It is also something that you need to practice in collaboration with the medics. So that as you diagnose your medication-related problems, these guys are diagnosing disease and you're working together to improve the quality of life of the patient. And you have to make it clear that you're doing this for the purpose of medication, addressing medication-related problems, and they have their clear-cut rule of diagnosing disease. Then you work as a team. Once you work as a team, the patient will be able to benefit. So once you're providing these services, you have to document. The reason I'm mentioning documentation is that in clinical practice we say if you've not documented it, then it has not been done. And we know that right now we are grappling with a situation where nobody knows what the pharmacist does. But if we do that, if we document what we're doing, then we are able to prove our work. Okay, we are able to tell these governors, hey, this is my work, this is what I'm doing for your patients, and it is improving their quality of life. So basically, I have a huge role to play. How does this then go into universal healthcare? Pharmacists have long been seen as people who just provide medication. But with universal healthcare, we are looking at the role of a pharmacist as a patient-centered practitioner, like other practitioners. And this is a practitioner who is working together with the nurse, who is working together with the medic, the lab person. We are having a healthcare team. So we have to claim our role back into the healthcare team. When you're looking at counties and sub-counties, pharmacists also have a role in public health and how medications are used outside there, because that's something that we've not really been focusing on. One of the problems I foresee with universal healthcare is actually where you have community health workers being given packages of prescription medication to walk around with. Now that is something as pharmacists that we have to put an end, because medication cannot be handled by all and sundry. It has to be handled by professionals, and for a patient to be able to access medication, it is only right that they have a comprehensive pharmaceutical consult. So as we go in and people are talking about universal healthcare, we need to put our foot down and say, hey, this is our role as pharmacists. Nobody is going to joke around with medication, because it's medicines are poisons. Nobody can actually be working on medication when they are not qualified. So those are some of the challenges that we have to get ready to address when we're looking at universal healthcare. We have to assert ourselves. We have to roll up our sleeves and work and do what we have been working. Pharmacists have been doing what they have been trained to do, dispensing, and they do it very well. The time for those wars is done. It is us guys who have not been doing what we are supposed to do. As a trainer at the university, I know that we have introduced a lot of postgraduate programs, and we are developing fellowships which should equip pharmacists in everything that I've been talking about. We have a very comprehensive clinical pharmacy program. We have a very comprehensive pharmacoepidemiology and pharmacovigilance program, and these are very important programs that bring out aspects of pharmaceutical care. We have been we've been running fellowships on renal pharmacotherapy, where we are training pharmacists to deal specifically with renal patients. We are also developing fellowships in infectious disease, in cardiovascular disease, in psychiatry, in oncology. So very soon, people should be able to come and attend those fellowships and postgraduate programs. And again, the master's programs are underway. You can apply anytime. These programs actually equip you with the basic skills, and not just basic skills, all the skills and the knowledge you need to be a pharmaceutical care expert. So if you're feeling a bit rusty and not so confident, please welcome to the University of Nairobi. We shall take you through and make you a good pharmacy consultant, because right now we need to be doing pharmacy consults and nothing else. We have to stop fighting with pharmtechs. And also, when you're doing a pharmacy consults, it's a very easy way to deal with quacks. You see, you'll not be fighting with a quack who cannot be able to do a pharmacotherapy workup for a patient. So we have to reclaim our space back into society. We have to look very critically at this universal healthcare thing and make sure that our patients are not being given inappropriate medication by unqualified people. So thank you for this opportunity. I'm looking forward to the conference, where I think I'll be able to contribute a lot more on the subject. Thank you.